Good morning to our viewers from USA. Good afternoon in UK, and good evening to our viewers in India. American Academy of Yoga and Meditation is a non-profit organization registered in USA. It was registered on November 5, 2019. Satyam Jnanam Anantam, that is truth, knowledge and infinite, is the tagline of AAYM. The organization is dedicated to education, learning and research on the use of yoga and meditation to make our planet a better place to live. It fosters an interdisciplinary approach linking science, arts, ethics, community, spiritual and sacred to enable humans to achieve the highest goals. Ganges Mississippi Dialogue is a sister organization of American Academy of Yoga and Meditation. Its focus areas are education, healthcare, and livelihood. It is being registered as a non-profit company in India. We have so far organized 14 webinars, some for the benefit of the common man and others for the persons in the medical field. Our today's webinar is COPD and Integrative Approach. Today our speakers are, I will introduce the speakers first. Dr. Peter Calverley. Dr. Peter Calverley is appearing on the screen, and he is a professor of respiratory medicine, an honorary consultant respiratory physician at Aintree Hospital, Liverpool. His main research interests are the physiology and treatment of chronic obstructive pulmonary disease and the management of chronic disease in general. He led the UK government strategy group on COPD care and chaired the National Institute for Health Research Respiratory Research Network for 5 years. He has been an editor of several respiratory journals and is a practicing doctor. He recently retired. He has been an editor and he is currently associate editor of the American Journal of Respiratory and Critical Care Medicine. His research is highly cited and he has published more than 300 peer-reviewed papers. Dr. Peter Calverley will speak on management of stable COPD, what a patient needs to know. Our next speaker, of course, this is not in order of their appearance while they will speak. Our next speaker is Dr. Dhar. He is head of pulmonology department in Calcutta Medical Research Institute. He is director, research and education, National Allergy, Asthma, Bronchitis Institute. He is Indian representative of ERS, academic secretary of Indian Chest Society, examiner for the MRCP in UK and India. He has large number of publications in Indian and international medical journals. He was abstract reviewer of American College of Chest Physicians meeting for 5 years. He is coordinator for the DNB course for the last 3 years. He is also closely involved in Mrityu Mrityunjay and You Breathe and We Care. And lastly, he is associated with a number of research projects. Dr. Dhar will speak on how do people get COPD, an Indian perspective. In fact, he will speak beyond this and will cover many other aspects. The third speaker this evening is Dr. Gautam Samadder. He graduated from the Netaji Subhash Chandra Bose Medical College in Jabalpur, India in 1984. He works in Columbus, Ohio, USA and 9 other locations and specializes in internal medicine, pulmonary disease, and sleep medicine. Dr. Samadder is affiliated with Mount Carmel West Hospital, University Hospital East, Barjar Hospital, Hocking Valley Community Hospital, and Mount Carmel St. Anne's Hospital. He is a former president of API, the AAPI, or American Association of Physicians of Indian Origin. He also held other responsibilities in that organization. He is associated with other organizations, fundraising, and members of various professional organizations. Dr. Gautam Samadder will speak on promotion of lung health, what means a patient, what measures a patient should take. Let me briefly introduce you the subject. COPD, that is chronic obstructive pulmonary disease, is a chronic inflammatory lung disease that causes obstructive airflow from the lungs. Symptoms include breathing difficulty, cough, mucus production, and wheezing. COPD is one of the major killer diseases in India. It is estimated that 10 million cases are diagnosed per year. When COPD sets in, the patients are treated for other ailments or symptoms. When the ailments continue for a long period of time, the patient consults a specialist, and maybe it is a bit late by then. Complications of COPD can become life-threatening. Beyond just shortness of breath and limitations of activities to include pneumonia, heart disease, hypertension, cardiac arrhythmias, and congestive heart failure. Let me not describe further and let the specialist speak. I invite Dr. Raja Dhar to speak. Dr. Raja Dhar.
Thank you, Sri Nirmala Bhattacharya. Absolute pleasure to be here. Thank you for inviting me. Hello to audiences across continents. So audiences in India, UK, and the US. It also gives me great pleasure to share the stage, the platform with experts like Professor Peter Calverley, for whom I'm actually a fan. Been trained by him, have looked up to him for years together, and you will have a treat listening to Professor Peter Calverley, Dr. Samadder, whom I've got to know today, but he's an expert in the field, and he will also be talking to you about other aspects, the rehab aspects of COPD. I will talk to you about two different aspects. So I'll talk to you about causation of COPD, but I'll also talk to you about the manifestations, the clinical manifestations of COPD. Can we upload the slides, please? Thank you. So I will talk for about the next 20 minutes or so, and there'll be some overlap between my talk and Professor Calverley's talk. But I guess that's a good thing, and it will reiterate some important points in the course of both the talks. Can we go to the next slide, please? So what you can see there are two different definitions of COPD. And we don't need to go into details, but we need to understand what COPD is. You heard Nirmala talking about COPD, alluding to the definition. So that's the definition in front of you from 2015. So the older definition talked about this being a preventable and a treatable disease. So first, the prevention part, and then the treatment part, which Professor Calverley will talk about. The fact that there's narrowing of the breathing tubes, and this narrowing of the breathing tubes results in airflow limitation. The airflow limitation is progressive by definition, and there is a swelling and redness within the breathing tube, what's called a chronic inflammatory response in the airway. And you can see the causative factors on that definition in the way of noxious particles or gases. So when we talk about noxious particles of gases, it alludes to air pollution, it alludes to smoking. And the fact that the worsening of the disease, which is called exacerbation, and comorbidities, which is its impact on other organ systems of the body, contributes to the overall severity of the disease. Now, if you go to the more recent definition, which came in 2017 as still the current definition, it talks about airflow limitation, and then it talks about two different compartments within the chest. One is talking about the breathing tubes, where we talked about the narrowing of the breathing tubes, and then it talks about the lung itself, alveolar abnormalities to noxious particles or gases again. So it alludes to two different compartments of COPD if you want. One is looking at the breathing tubes and the other looking at the lung itself. Let's go to the next slide, Anjali. Thank you. So this looks at the causative factors, the development of COPD. So the development of COPD is an interaction between environmental factors. And when we talk about environmental factors, we are talking about smoking, of course, which is traditionally the causative factor for COPD. We are alluding to air pollution, and that's something which is very much in the news. But especially for India, we are talking about biomass exposure, and I'll go back to this in the latter part of my talk. So all these factors that we talked about, and if you have a genetic predisposition, if you've got a family history, in a minority of cases, that would interact with the environment, resulting in the causation. So in the causation, the lung growth of individuals might be hampered. If the lung growth is hampered, if there's narrowing of the breathing tube, the lung function declines over a period of time. And this is the manifestation of the inflammation, the swelling, the redness within the breathing tubes and the lungs that we talked about a little while ago. Let's go forward down the slide, please. So you have two different boxes there. The first box talks about the basic physiology, which is airflow obstruction, and then the clinical manifestation. So the cough, the phlegm, the wheezing that we have in patients of COPD, along with the breathlessness, the episodes of worsening of the disease, which we call exacerbation, and then the spillage of the inflammation to various organs in the body, the heart, the kidney, the brain, etc., which is the comorbidities that we talk about. So this is something we have talked about already. The disease in two different compartments. One compartment is looking at the breathing tubes and the narrowing within the breathing tubes, and the other is looking at the lung and the destruction of lung tissue, which is talked about in medical terms as emphysema. So chronic bronchitis on one hand, which is the redness and swelling within the breathing tubes, and on the other, there is destruction of the lung units called alveoli, resulting in emphysema. And that's what you see here, the fact that there are two different compartments and then there is an area of overlap, and the fact that it involves the lung, but also involves other organs and systems, which is alluded to in the slide as the systemic effects of COPD. So the lung effects of COPD and the airway effect of COPD on one hand, and the systemic effects of COPD on the other hand. Let's go to the next slide, please. So traditionally, when I did my medicine, I was taught that you could not have COPD without having ever smoked. So smoking, active or passive, was the most important factor in the causation of COPD. In fact, the only factor in the causation of COPD. And you can see that alarming fact on there, which talks about one cigarette equating to 11 minutes of life being lost. And I want you guys to remember that. I know there's a lot of smokers in the audience, I'm sure. So one cigarette translates into 11 minutes of life being lost. And you can calculate the number of cigarettes you've smoked and the number of years that you've lost. And maybe that would be the motivation to stop smoking for the smokers. And for the ones who don't smoke, you can carry this message forward in educating others who smoke to stop. I won't go through in great detail with this particular slide, but look at this slide in your own time. It tells you from the top to the bottom. So from the top where you've lighted your cigarette down below, the chemicals that are there, the toxins that are there within the cigarette, and what poison there is. So it's not one poison. You can see the list in blue and pink on there. Those are the poisons that you're inhaling when you inhale on a cigarette. And the fact that smoking 1 to 4 per day can be injurious as low as a number as that. In India, smoking happens in various forms. It's not just in India, it happens in various forms throughout the world. However, we're talking about India because the photographs from there, the cigarette you can all identify. All the Indians who are watching this will identify with the biri. You can see the hookah, which is a menace now throughout the world and is as toxic, as harmful, if not more, compared to smoking the cigarette. And then the north of the India, a lot of you would be identifying with the chillum on that photograph. Next slide, please. So that's the hookah. Go forward on the slide, please. This is a study which is quoted from Malaysia. No, the previous slide, please. Yeah, so from Malaysia, which talks about being in a hookah bar and smoking a hookah for 4 hours, and the fact that that equates to 100 to 200 cigarettes, depending on how smoky it is, how much you're inhaling, how much of the time you're chatting, and how much you're inhaling. That's 100 to 200 cigarettes and 100 times more amount of nicotine. So it's no different anywhere. The study happens to be in Malaysia, and I've borrowed that slide from one of my friends, but it's the same throughout the world. Next slide, please. So the reason smoking cessation is important is on that particular slide. And I'll take a minute to take you through that slide. So the top bar on there, I hope you can see my cursor, but the top bar on there is someone who's never ever smoked and lives in a clean atmosphere, not akin to what we have in Kolkata or in India. And you can see that there's a gradual decline in lung function, but even after 75 years or beyond of life, it amounts to no more than 25% of decline in lung function. And then you have this individual who starts off at the same point, but has smoked from the age of 25, undergoing a decline in lung function rapidly and losing about 8 to 10 years of life, having smoked for, say, about 50 years in total. However, I want you to focus on the red lines on there. And that demarcates points at which an individual stops smoking. So if you stop smoking at that particular point, you gain about 5 to 6 years of life. If you stop smoking even as late as 60 years of age, you still gain a few years of lifetime, but more importantly, you gain in quality of life. So carry home message, never too late to stop. Stopping should be the foremost thing in the management of COPD. So why is it difficult? It's one of the most addictive substances in the world, that's smoking. So as doctors, we need to have good communication skills. We need to be compassionate. We need to be patient in trying to wean people off cigarettes or get people to stop smoking. Next slide, please. So there are various agents which can help you in stopping smoking. There are medications, tablets. There are nicotine chewing gums. There are nicotine patches. There are the e-cigarettes, which have themselves become dependence-producing substances. However, overall, it's the counseling from doctors and other literate, educated people which helps people to stop much more than the other replacement therapies that we have here. These are to support. The individual has to have the mind steps set to stop smoking. Otherwise, it's never going to happen. Next slide, please. So I won't go through all this. There are these tablets. The doses are on there. This is something that is not available or should not be available over the counter. Your doctor should be the person who prescribes a bupropion or a varenicline, which are tablets to help people to stop smoking. Next slide, please. So that's about the smoking part. The slide that is appearing in front of you now is a famous slide from Dr. Sandeep Salvi's work, which looked at biomass cooking and the risk of COPD. So you see the lady there in a poorly ventilated kitchen, sat in front of the chula, and the kid, 5-year-old kid, who's standing by and passively inhaling all the smoke from the chula. And that's how Indians would get COPD at a much younger age as compared to what others, the Westerners, would get, the UK population that Professor Calverley looks at would get. So that's a huge problem. About 60% of the Indian population still cook with biomass, a number probably which is an underestimate rather than the right estimate. And these are various ways you can improve ventilation, even if you cook in biomass, even you cook with a chulha. So improve kitchen ventilation, have a chimney in the kitchen, have an exhaust fan, low smoke chulhas are available. But more importantly, the Indian government is doing a lot of things about promoting LPG, trying to get it into the rural areas. There are electric cook stoves and solar cook stoves are improving. However, it's important to ensure that even if you have to use biomass, which is still compulsory in certain parts of the country, there's good ventilation, kids stay away from the kitchen, there's a chimney in the kitchen, and so on and so forth. And LPG would be the thing for the entire country. Is this important? We spoke about smoking-induced COPD. We are now talking about biomass smoke COPD. And suffice to say that the two diseases seem a little different. The tobacco smoke COPD seems to cause more damage to the lung itself, the emphysema that I spoke about a little while ago. Whereas the biomass smoke COPD seems to be a disease more of the breathing tubes, the redness, swelling of the breathing tubes, the narrowing of the breathing tubes that I talked about seems to be more profound in the biomass smoke COPD as compared to what it is in the tobacco smoke COPD. There's overlap in both the groups, so you have overlapping populations. However, there is a predominance of emphysema, lung damage in tobacco smoke, and there's more of the chronic bronchitic, the airway component in biomass smoke COPD. Next slide, please. So that's about biomass briefly. This is about reducing occupational exposure. And you can see there are big coal belts nearby where I live. So the entire Durgapur, Bokaro belt is full of coal. That's one occupation where you get a lot of COPD. You can see the various mining industries on there, which might give you COPD. So occupational exposures is one big group. And next slide, please. And then there are these, which we use on a regular basis, which are the mosquito coils, which are your good nights, etc., which gives you a good night's sleep, but also cause immense damage to your breathing tubes. And I would advocate these rackets which have come in, but maybe the good old mosquito net would be the best way forward. So these are all important, remember. So the mosquito net, if you keep that lighted for 6 hours at night, that is equivalent to smoking 50 cigarettes, 50 cigarettes with one mosquito coil, which runs for a 6-hour period. It's less with the electrical ones that we talked about. However, there's still a significant risk of the airway getting damaged with COPD. Next slide, please. So very quickly, in the last 5 minutes, I'll take you through these. So this was a JAPI editorial that I wrote a few years ago. And this looks at the top 10 causes of death in the southeastern region. And the commonly envisaged causes of death are down at the bottom there. So you can see the HIV, the tuberculosis, and the malaria. And you can see between 2008 and 2015, the numbers gradually coming down and the projected numbers coming down even further thereafter. However, you see COPD on there. And the first is the numbers are greater than all these three menaces put together. So the TB, the malaria, the HIV put together, the numbers with COPD are far greater. And the fact that the numbers are rising is what makes COPD a potent threat and the reason why Shri Nirmala Bhattacharya has arranged for this symposium on this topic today. Next slide, please. So let's keep going forward. Yeah, so lots of patients, no, previous slide, please. So lots of patients in India, 5 lakh people die due to COPD every year. So this is data from 2012, 2013. The numbers have gone up by about 20% by now. So 6 lakh is what the 2080 global burden of disease data shows, 4 times greater than the people who die due to COPD in our compatriots, so the US and in Europe. Next slide, please. So these are the top 10 causes of death in Maharashtra, one state where COPD is middling. Actually, it's not one of the states where COPD is the highest. And you can see the numbers on there for yourself and the other causes, so-called causes, potent causes of death, the cardiac cause, the stroke, the ischemic heart disease, accidents, etc. You can see COPD head over high over the other causes as top 10 causes of death. Next slide, please. And the economic burden significantly increasing over the years. So this is a paper from KGR Murthy. famously quoted everywhere at meetings, and you can see the costs going up, escalating over a period between 1996 and 2016. That's the economic burden. And what's important is the green bars on there. If we follow the guidelines that Professor Calverley will talk about in management in a few minutes, you can actually reduce the cost, which is shown by the green bars on there. And it's a significant drop. It's 1/10 the cost if you just follow guidelines in treatment. And if you don't follow them, the costs escalate 10 times. Next slide, please. So non-smoking COPD we have talked about, and we have said it's important in India. The fact that about 60 to 70% of Indian households use biomass fuel. The number has probably come down with the LPG programs getting more and more widespread. However, there's still significant numbers, and chronic exposure to biomass fuel has been shown to lead to COPD without a semblance of doubt. Next slide, please. So the last part, the last 2 or 3 minutes, we'll run through these slides quickly. The fact that this redness and swelling in the airways in the lung spills over and goes to various organs. It's better to imagine, it's not as simplistic as that, but it's better to imagine it this way. It helps clarity of thought. So it can go to the muscles, it can go to the bone marrow, it can enhance the aging process. So people, along with their lung age increasing quickly, the entire body ages more quickly, and there might be an autoimmune component to this systemic inflammation, which involves the entire body. So it's multifactorial, multiple causes for this. Next slide, please. So this is from looking at the heart, a very large study called the Framingham Heart Study, which has now been about 70 years since it started. Next slide, please. Lots of papers come out, so more than 1,000 papers being published on the Framingham Heart Study till date. Let's keep going forward. And you can see that reduced lung function is an independent risk factor for death from heart disease. So I'll say that again, because that's the one carry home message I want to deliver. The fact that if you just have chronic lung disease, COPD, your chances of dying from heart disease are far greater, and it keeps increasing as the person ages, which is, I guess, predictable. Next slide, please. And the fact that reduced lung function increases mortality, increases the number of deaths, even when you set smoking aside as a risk factor. So independent of smoking, reduced lung function increases mortality. Next slide, please. So this is the PURE study, which got published not so long ago. And let's keep going forward, please. So this is Dr. Salim Yusuf, who's published this study, and it looks at the healthy adult South Asians and the fact that their lung function was 35% lower when you corrected it for age and gender when compared with the Caucasian population. So our population, the South Asian population, seemed to have 35% lower lung function. So you're starting off with a disadvantage. So to get to the same degree of lung damage and obstruction of the airway, you have to do 35% less to have the same degree of severity. And I think that's something which us Indians need to keep in mind. Yeah, keep going forward, please. So those are the list of comorbidities that we have. So the ischemic heart disease, the hypertension, the diabetes, the stroke, arthritis, and anemia. Keep going forward. And let's keep going forward. I mean, I should finish in the next minute or so. So let's keep going forward. So heart attack under COPD is important. Weight loss and muscle mass loss is important. Next slide, please. So weight loss and muscle mass loss is important. Patients with COPD are prone to getting anemia more, and this needs to be treated with oral iron and erythropoietin. We talked about the bone marrow getting affected, and you can see the structure of the bone in patients who are COPD doesn't look very different to the structure of the lung. There's holes in it all over. They match in appearance, and that's the osteoporosis, the lack of loss of bone mass that you get in patients with COPD. Next slide, please. And the fact that osteoporosis is much greater, the consequences of osteoporosis and the consequences of breathlessness match. So if you have osteoporosis, your spine is bent, the bones around your chest are not as functional as they would be in a person with normal bone mass, and breathing becomes a greater struggle. So someone with just obstruction and no osteoporosis will have greater advantage in breathing as compared to someone who has the osteoporosis. And then, very important, the seclusion that comes, the depression, the anxiety that comes with COPD is a disaster, and that needs to be checked. People need to be counseled. Some people would need psychiatric treatment for the anxiety and depression that comes with the breathlessness associated with COPD. Next slide, please. And all this will be integrated into the pulmonary rehab that Dr. Samadder will talk about in the end. Last slide. Next slide, please. Yeah, so that's my concluding slide. So I conclude by saying that COPD is probably the most important emerging cause of morbidity and mortality, at least in our country. And the fact that while smoking COPD is extremely important worldwide, there are multiple causes of COPD, and the other causes too are very important in Indian scenario. The pollution, the mosquito coils that I talked about, and most importantly, the biomass I spoke about are extremely important. The fact that the smoker COPD and the non-smoking COPD are slightly different animals, and this needs to be kept in mind when practicing physicians like myself treat my patients with COPD on a day-to-day basis. And the fact that this is not just a disease of the lung and the breathing tube, there are other organs like the bone, the brain, the soft tissue, the muscles, etc., which get damaged from COPD. And this again needs to be addressed when you treat patients with COPD. Thank you very much for listening.
The first question is, should those whose parents have or had COPD are more likely to suffer from COPD?
So there is, Nirmaloda, a very small increased risk, genetic risk. It's a small risk, much lesser than what you have in patients who have asthma, for instance. However, there is a 1 to 2% population who have a genetic link in COPD, and often the gene and the environment linked together, like I said, and hence people who have parents who've got COPD, the risk would definitely be greater. We don't understand all the genetics of COPD, but there's definitely a greater risk in people who have immediate relatives who have COPD.
The next question is, what is the life expectancy of someone with COPD?
So the life expectancy, if you look at the Indian population, without having a chronic disease, is about 68 and 69 years. That's the normal life expectancy in India today. However, if you look at any chronic disease, and especially COPD, in a smoker, where we have the most amount of data, if you've smoked for 50 years and smoked an average of 20 cigarettes a day, and you have good going COPD, you lose about 8 to 9 years. So you subtract that from the 69, you get to 59 to 60. So that's your life expectancy with bad COPD. We have data about smoker COPD. I don't think the data from non-smoking COPD would be very different.
Okay. I now invite Dr. Peter Calverley. Thank you, Raja,
Thank you.
for
Thank you.
all that you have said. Now, Dr. Peter Calverley will basically speak on management of stable COPD.
Thank you very much indeed. It's a great pleasure to be participating in this seminar, and also to see some good friends from India as well who kindly involved me in this program. What I'm going to be talking about today is the management of COPD. So perhaps the first thing to do is to get the slides up. We had a little bit of technical problems at the start, but if we could get the slides, then I will be able to begin. Because much of, well, not much, but a certain amount of what I've got to say will have been covered already. And that is right, and as it should be. What I'm taking the view is that I'm trying to focus on what the patient needs to know about the management of their illness. These are my disclosures, which actually do show that I've been involved with a lot of companies who've studied drugs in COPD. And of course, I'll be talking about that next. Next slide, please. So what does the patient need to know about COPD? Well, we've just heard a lot of the answers to this. Can we go back to that, please? Sorry. Thank you. That slide. Thank you. What do they need to know about COPD? We've heard a lot of the answers to this at the moment, but when you come to managing the patient, you've got to make sure that the patient understands what the condition is that they have, why it might have affected them as far as you can help them in that. You're going to be telling them quite a lot about what they can do about their condition, and that they won't necessarily need the same treatment as somebody else who had their condition. They need to know how to take their treatments, and they need to know what happens if they get worse, the exacerbation to which Dr. Raja was referring just now. Next slide, please. So I'm going to come back to the second of the definitions which we showed, and the messages I'm going to take out of this, because this is going to be important in explaining to the patient what's wrong with them, is that COPD is common, preventable, and treatable. I'll say a word about the airflow obstruction. You've heard a lot about the symptoms already, and I'm not going to say so much about the noxious materials. Next slide, please. Well, as an example, you've seen the Indian figures, which is most relevant for this audience, but just for comparison, here's something about how common COPD is in the UK. This is a survey conducted by the British Lung Foundation. It's and the Department of Health in England. It's estimated that there are over 300 million people in the UK population, which is about 66 million, with evidence of COPD. Many of those have COPD that's not very severe, not as severe as some of the cases you were hearing about before. But of that 3 million, about 2 million, 2/3 of them, have never had a diagnosis. Even so, that still leaves a sizable number of people who we do know about who have evidence of lung damage, which is typical of COPD. And it actually explains, in our country, and I suspect in yours as well, COPD is a disease which tracks affluence or lack of money. People who are well off don't tend to get COPD. People who are poor do. And it explains quite a lot of the difference in life expectancy between poor and rich people in the UK. Indeed, COPD is about the 5th largest killer disease in the UK. It's probably going to go up to the 4th soon. So it's still a very real problem. It's particularly a problem in our older people, but it still can affect younger people as well. Next slide, please. You've heard already about the major causes of COPD, and in where I live and work, tobacco smoking is a crucial factor in driving this disease. And it's also one of the things which you've got to get the patient to understand, because if they realize that their smoking is making them ill, they will take steps to change that. And sometimes they will look at other things in their life, their exposure to smoke, to fumes, to pollution, and say that's why they've got their illness. And part of your job is to say, well, all of these things taken together build the fire which is now burning inside your lungs. Biomass is a problem which we've already discussed in India. One word as well, small babies are more likely to get COPD when they grow into adulthood. Things that influence early life development, as we've said already, are important. You saw that dramatic picture of the little girl in the poorly ventilated kitchen. And certainly as well, a factor that affects some people is that they feel guilty about COPD. It's a disease they're ashamed of. They know deep down that it was their behavior very often that led to this disease. And it's one of the reasons why it gets covered up. Now, obstruction can lead to lots of the symptoms. It's probably the main thing that causes symptoms. By obstruction, we mean the inability to empty your lungs quickly and completely. As a result of that, you have air left behind in your lungs, what we call overinflation, hyperinflation. You realize quite quickly if you try and hold your breath, breathe in and then don't breathe out completely, that you'll get breathless. And that's especially a problem with exercise, and it's the major symptom of COPD patients. They need to know there's a reason why this happens to them. It's not magic, it's a direct consequence of their lung damage. They also need to understand that, particularly in the winter months, that they might well get viral or bacterial infections that will make them sick. And for the people who've got a lot of lung damage, that might lead to them going to hospital. So a realistic explanation to the patient of what goes on is really important. Next slide, please. Many of the patients will also have this sort of test. It's spirometry. It's a simple plot of the amount of air you breathe out, volume on the y-axis, against how long it takes to breathe it out. That's time on the x-axis. And you'll see that the total amount of air, the forced vital capacity, which you get out in 6 seconds, in this person was 5 liters rather, and most of it, 80% of it, came out in the first second. That's a healthy lung. On the other panel, you see somebody who's got COPD, and their FEV1 is reduced, and it's only about half of the air gets out of the lungs before they stop breathing out. These numbers are important because they set the guidance as to how you approach treatment of the patient and what you're going to tell them about their prognosis, which is why if you can get data like spirometry, it makes your diagnosis more certain and your management clearer. Next slide, please. And the final thing in this section is that you need to understand and indeed explain to the patient that this is a condition that affects them both physically and emotionally. Certainly, the poor lung function leads to the symptoms. Exacerbations makes them feel miserable and might take them to hospital. And we've heard about the effects on their muscles and their loss of mobility. But remember the emotional burdens. This is a chronic condition that strains relationships. People can get depressed or anxious with it, and it promotes social isolation. There's a lot of areas out there where therapies that are not based just on inhalers and medicines can be helpful. So what can we do? Next slide, please. Well, there's a series of general health measures which are sort of obvious from what you've heard already. Stopping smoking, whatever the stage of disease. That you can tell patients confidently that will reduce the number of flare-ups of the disease, slow down their illness, let the treatment work better, because if you smoke, some treatments, particularly inhaled steroids, don't work as well, and it will prolong their life. You need to sit down with them for a moment or two and plan quitting the smoking. Help use what support services are available, and also use some of the drugs you heard about. Regular exercise is important to help their illness, help the patient cope with their illness, and learn not to be afraid if they get breathless. Immunizations, influenza we know about, pneumococcus we know about. We must add COVID-19 to that now and likely in future. Pulmonary rehabilitation is an important therapy if you have access to it. And here you can see one of the exercise classes at my hospital. Next slide, please. And the components of rehabilitation are threefold in the main: an exercise training program, education covering most of the things I've talked to you about just now, and psychosocial support, which is individualized to the patient. You have a team of different people with different skills who can deliver that. In our system, people come in twice a week over an 8-week period, and then they have a home exercise program to back that up. And this can produce dramatic improvements in the well-being of somebody who would otherwise be unable to do a lot of daily tasks. Next slide, please. We now use what's called the GOLD assessment scheme to decide how to plan our treatment, particularly drug treatment. Next. First of all, we confirm the diagnosis spirometrically, and then we grade the severity of the lung function impairment, because that's relevant in terms of prognosis. But for a lot of the treatments we use, we relate them to the intensity of their symptoms, particularly breathlessness, and their likelihood of having had flare-ups of the disease or exacerbations. So you end up with a group of people. Last slide, back please, back please. Thank you. You end up with a group of people who have very few symptoms and little risk of flare-ups, and others who have a lot of symptoms and many flare-ups, and the treatment is going to be individual and different. Next. If you look at the drug treatments, we like to give treatments by inhalers because it reduces the number of side effects. Short-acting drugs are used for reliever treatment, and long-acting drugs to maintain patient well-being. Bronchodilators are drugs that cause a relaxation of the airway smooth muscle inside the breathing tubes. There's different sorts, beta agonists and antimuscarinics, that work through different mechanisms to do this. Anti-inflammatories deal with the redness that you're hearing about inside the lungs, the inflammation. There's drugs like inhaled corticosteroids and others called PDE4 inhibitors. We keep high doses of corticosteroids when the patient's deteriorating clinically, and that's when we give them antibiotics as a rule. Next. This is the UK National Institute of Clinical Health Excellence recommendations, which I put up for simplicity because, in fact, what they're saying is quite straightforward. The top panel in grey covers a lot of the things you've already heard about, including managing comorbid conditions. The bottom panel in white talks about the need to use inhalers properly, and particularly to make sure that the patient knows how to use them and is using them correctly. If the inhaler is not used correctly, it won't be very effective. Next. Next slide. This is where people, very often by the time they come up to hospital, are needing treatment. Generally, short-acting drugs haven't worked very well for them. They may still have lots of symptoms. Their exercise capacity is limited. So you'll usually offer them then, at least in my country, a combination of a long-acting inhaled drug, a beta agonist, and an antimuscarinic drug. And more people, particularly if they've had trouble with exacerbations, will end up with the addition of an inhaled corticosteroids. Some people with a past history of asthma or with some other features suggesting they respond to steroids may use an inhaled steroid combined with a long-acting beta agonist before they use the dual bronchodilators. But although it looks complicated on this slide, in practice it's relatively straightforward to sort out. Next. Why use two bronchodilators? Because people feel better. This is a study measuring a measurement of health, which is called the St. George's Respiratory Questionnaire. This is what happened with people who were on a long-acting antimuscarinic, and this is the people who had the two bronchodilators, and basically you can see that they had more improvement, and in fact it was repeated in another study. Patients feel better if they're on two bronchodilators. Next. Why add an inhaled steroid? This is a very big study, but it does provide a clear answer for people who have a lot of bad disease and a lot of trouble with exacerbation flare-ups. The likelihood of exacerbating is cut down if they have an inhaled steroid in the regime, and it's even lower if they use all three drugs, an inhaled steroid and the two bronchodilators together. And this is just a plot of the time to first event. Next. The key thing about asthmatic features that was mentioned in the NICE guidelines is very much what the blood eosinophil count is. The eosinophils are a form of white blood cell. They're often raised in parasitic infections, but they have a general body maintenance function, and some people have higher levels than others. The reasons for that are debated. If you tend to be at the high end of normal, you are more likely to exacerbate, even when you're on two bronchodilators. But if you're on the triple regime, you really don't exacerbate. You get a big improvement in the risk of exacerbation, whatever your blood eosinophil count is. And so you can actually say that it's this group of people up here who really need the extra inhaled steroid. Next. Next slide. I hope. It's a very nice slide, but we could do with the next one. Yes, there are other things you can give. In the US, there's a drug called roflumilast, which can help a little bit in very sick patients who might get hospitalized. Long-term antibiotics, and there's a lot of antibiotics used in India, can, in selected patients, help, but generally those are patients who've had maximal treatment with the other therapies I've discussed. Mucolytic drugs that help you cough spit better, they can help some. There's a drug called N-acetylcysteine, widely used in Southeast Asia. But some things you've got to try and avoid. Don't go on to regular steroid tablets. They're cheap and lethal. They'll damage your bones and shorten your life. And then there's very expensive therapies, which, although they're very expensive, aren't very effective. So they're not really relevant in this conversation. Next. Next slide, please. I've put up here 3 different inhalers. The blue inhaler in the middle is the commonly used Ventolin inhaler. That's the one that people take as a rescue treatment. It's a pressurized metered dose inhaler. There's a dry powder device next to it. That's the kind that was used in those inhaled steroid studies. And there's a soft mist device to the other side of that, which is made by Boehringer, and that was the one that was used in the antimuscarinic studies. Could you go back, please? Unless you'd like to give the rest of the talk. Thanks. Good. The point about them is they're each quite different, and they each require the patient is shown how to use them. If you don't show the patient how to use them, you might as well not bother giving them. Next slide, please. A word about exacerbations. Mostly this can be managed at home. People may take a course of antibiotics or a course of steroid tablets. But if people are very unwell, they're going to end up in hospital, getting nebulized bronchodilators, perhaps intravenous steroids and antibiotics, oxygen treatment, and for some, non-invasive ventilation. The point about hospitalization is it's a serious event, and people who get into hospital with their COPD are seriously at risk for their future health. Next. So in conclusion, managing COPD is multidimensional and multidisciplinary. Understanding what you have and what you're taking and which treatment you're taking is crucial. The patient has to play a part in this. General health measures are very important, as I've tried to stress throughout, including psychological well-being. There's clear evidence-based guidance which will help the doctor select the best treatment for the patient at different stages of their illness. An early recognition and active treatment of exacerbation will save trouble later on. All of this is to show you that although you can't reverse the lung damage of COPD, it is nonetheless a treatable and preventable condition, just like it says in that definition. Thank you.
Two questions for you. First question is, can COPD continue for life?
Yes, very much so. Once that lung damage has occurred, I dropped the slide that said that in the interest of time. Once that damage has occurred, we can't reverse it. Maybe very, very early on, but to all intents and purposes, by the time a doctor gives you a diagnosis of COPD, the damage to your lungs is going to be present. And what our treatment does is it tries to lessen future deterioration and help the patient cope with better with the problem they have.
Now, during your presentation, you have mentioned about something about influenza. Now, should the COPD patients regularly take vaccination for influenza as well as pneumonia?
Yes, they should. Both are important. Both are very cheap, highly cost effective. The influenza vaccine, of course, changes each year, but it will really cut down mortality. And there's good data, mainly from the US actually, that really has an impact on the chances of you getting into hospital. It reduces them, and the chances of you dying, it reduces that. So influenza, very worthwhile.
And the last question, can a person with COPD get better?
Yes. They can get better in the sense that they have far fewer symptoms, they lead a much more active life, they are feeling good in themselves. If you look inside their lungs with a CT scan, they may still have lung damage, but they can lead full and active and rewarding lives. And that's why it's important to support the COPD patient with all this physical stuff I've told you about, but also emotionally and helping them manage their illness better in terms of their mental state.
Thank you, Dr. Peter. We'll now invite our third speaker, Dr. Gautam Samadder.
Thank you.
Straight away, Dr. Samadder, the floor is for you.
Thank you, Mr. Nirmala Bhattacharya. First of all, I'd like to thank the organization for inviting me, along with so many good and honorable speakers, Dr. Dhar and Dr. Calverley. And I really enjoyed their talk. And my job is little easy because both the speakers covered a lot of things which I'm supposed to say about lung health and prevention of COPD. So I just want to reiterate the different topics which are very essential for COPD prevention. You heard both the speakers talking about the treatment, but I'm going to re-emphasize certain key points which the viewers should know how to prevent COPD. And the first and foremost, I want to emphasize that lung growth starts when the child is in the uterus and in the early childhood, and any exposures during that time does decline the lung health or lung growth. And as we all know that as we age, our lung function decreases. So keeping that point of view, we want to see how we can decrease that lung function growth by taking certain measures. So my emphasis will be on 5 topics. The number 1 will be tobacco smoke. As you heard from Dr. Dhar and Dr. Calverley, that smoking, both active smoking and passive smoking, has a significant impact on lung health. So we do encourage people to smoke, even if they cannot stop smoking. Decreasing the cigarette intake from 1 pack a day to half a pack or 1/4 does play an important role in the lung measures, especially FEV1 and the ratio which we monitor on a daily basis. Second thing is we do give medication to stop smoking. Dr. Calverley mentioned the medication, but also we are in US. We highly emphasize that tobacco smoking. We don't believe in tapering the cigarette smoking, like reducing. We believe that if you call it cold turkey, you suddenly stop smoking. That has a much beneficial effect than slowly tapering the number of cigarettes, because there is a high tendency of people to go back to smoking when they do it slowly rather than just suddenly stop smoking. Sometimes it is possible, sometimes it's not possible. So next important intervention is the indoor air. And as you heard that indoor air, especially fuels, people use kerosene oil and other fuel for cooking and all, that plays a very important role. And the recent research is about 3 billion people are exposed to smoke from different sources. And increase exposure to these pollutants does lower the lung function, increases the infection, and it accelerates the decline of the lung function. So cleaning the indoor air is also very, very important. Also, another common pollutant in indoor is this nitrous oxide, which comes from the gas stoves and gas furnaces. So using filters and purifying that air will help a lot in declining the lung function and improve the lung health. Also, nitrous oxide increases the airway inflammation, so that if you decrease the quantity of nitrous oxide in the indoor air, it will help in improving the quality of air, and also improve the lung function. Under the same topic, I would like to discuss outdoor air, especially ozone and sulfur dioxide, which if increased quantity decreases the lung function. And whenever you have high quantity of these in the outdoor air, it will affect your lung function. So decreasing the amount of these pollutants in the outside air also will improve the lung function. Next is topic is respiratory infection. As you heard Dr. Calverley saying about the different vaccine, the problem with COPD is that any infection will make the lung function deteriorate more than usual. So, preventing the lung infection, especially influenza, pneumococcus, and other upper respiratory infection is very, very important. So the goal is in US, we are very familiar of giving flu vaccine every year and pneumococcal vaccine every 5 to 6 years. And with now the COVID coming into play, I'm sure people will be, vaccinated and getting the booster dose so that, any kind of upper or lower respiratory infections are prevented. And the way the infections works is when you have an infection, there is a viral overload and there is mediators which are, released from the cells, and that causes inflammation, and that makes the lung functions worse, especially FEV1, you will have more obstruction. So if you can prevent the infection, then your COPD will be better controlled, and the life expectancy will be higher. Next important topic is the nutrition. Nutrition does play a very important role along with the other treatment for COPD. And some of the vitamins which are very, very important is vitamin A, vitamin E, and because they increase the FEV1, which is the forced expiratory volume in 1 second. Also diet which are high in fruit, vegetables, oily fish, and cereal, whole grain, they do increase the FEV1. So along with the other treatment, diet, a well-nourished patient will perform better than a malnourished person. Also, the traditional diet, high intake of meat, also potatoes, and lower intake of soya beans and cereal, they decrease the FEV1. So when you are doing a diet, just make sure it is a balanced diet which has the essential nutrients to help you cope up with COPD. Next very important topic is physical activity. I think Dr. Calverley showed a slide about the pulmonary rehab. Along with the treatment, pulmonary rehab is one of the most important factors which people should be aware of doing it along with it, because just treatment alone will not decrease the acuity of your COPD. And during the rehab program, it is not just exercise. When we refer a patient to a pulmonary rehab program, it is very important that they go through the education process where they understand the chronic process of COPD, why we have COPD, why one person is more susceptible than the other. So education is very, very important. Also, when we see a COPD patient in our clinic, it is very important to teach them how to use the inhalers, because most of the unsuccessful treatment study which have seen is that patients don't know how to use inhaler. So it is very important that either you or your staff shows a patient how to use the inhaler. And there are different types of inhalers, and the mechanism is different. So instead of leaving the burden onto the patient and the pharmacist, it is very important that your staff or you educate the patient how to use inhalers. And during the pulmonary rehab, they do give nutritional support and also graded exercise to increase your exercise tolerance. So the main goal of pulmonary rehab is to improve the quality of life, improve your exercise intolerance, and also your physical activity. As you know, with aging, your lung function will deteriorate. So exercise tolerance, if you improve, then that will help your underlying COPD. Then the last topic I want to touch base is those who are overweight, their lung function deteriorates. So body mass index, body mass index is your weight divided by the height, and also waist circumference is very, very important tool to see how your lung function is. And it has been shown that body mass index and increased waist circumference decreases the FEV1 and FEC, which are an important parameter in monitoring the lung function. So if all these topics which I have discussed, the patients put into consideration, I think it slows the process of COPD. And there was a question asked about COPD, that whether it will go away. The recent literature, the COPD does not go away, but if you do all these measures, the further progression of the disease can be halted, and you can have a stable lung function where you can at least do your normal daily activity without any compromise. So with that, I'm done with my topic. As I told you, some of my things have been already covered by the two speakers, and it was my honor to participate in this program with them. Thank you.
Thank you, Dr. Gautam. I think Nirmalaji is facing some problem with his internet connectivity. We have a question here from a few of our viewers. So may I ask the question to you, Dr. Gautam?
Sure.
I think we have Dr. Rajadhar and Dr. Calverley also here with us. So one of the viewers has asked us here that can doing some breathing exercises like pranayama help in managing and curing COPD? The question is open to anyone who would like to answer this.
Let me answer. I have a very small exposure to yoga and meditation, but I was a part of a program called Art of Living, sponsored by Shri Shri, and the breathing exercise, which is very, very important, and it's part of the pulmonary rehab program, which I was talking to you about, graded exercise. So in my view, with my 30 to 40 years of experience in pulmonary field, it looks like the breathing exercise which are educated through this yoga and meditation program will help COPD to expand their lung volume. I will ask Dr. Dhar, maybe he may have more exposure to yoga.
So Dr. Samadder, absolutely bang on. So I think it's a topical question because not so long ago, 2 months ago, the All India Institute of Medical Sciences, which is the biggest body we have for medicine and for pulmonology in the country, came out with the post-COVID rehabilitation guidelines, and they have integrated yoga and pranayam into the post-COVID guidelines. The current director of All India Institute of Medical Sciences had partnered with us not so long ago in looking at yoga as a part of rehab in COPD. We did this study in about 12 centers throughout the country, and we found that integrating yoga into the rehab program actually increased the acceptability of the program first, and also made it more effective, especially from a home rehab point of view, which is probably the way forward in our country rather than institutional rehab, which is far more popular in the UK and in the US.
Just to add to that one small point, I think it's entirely appropriate that yoga will help. It will help. That's what I said about the whole well-being, a holistic approach to the patient, especially in countries like India, where it's very culturally acceptable and people are familiar with it and have confidence in it. I suspect that a lot of the help is in terms of how the brain processes the information it gets from the lungs. And there's a whole neurophysiology that shows how you can control your symptoms of breathlessness by which parts of the brain get activated. I'm sure the yoga helps in that regard every bit as much as anything mechanical, like changing the lung volume. It's always much harder to show these things change lung volumes. Rehabilitation does not. It has a terrific impact on people's well-being. So yes, add in yoga.
Right. Thank you so much. One more question has been asked by our viewer is, can COPD lead to lung cancer?
Well, perhaps I'll take that first. COPD is associated with an excess risk of lung cancer. And that's even when you allow for differences in smoking intensity, smoking materials. At the most conservative estimate, you are about 2 to 3 times more likely to develop a lung cancer if you have COPD than if you are a smoker who doesn't have COPD, because not every smoker gets COPD. And so much so that it's one of the things that's been used in the National Lung Cancer Screening Program in the UK to try and highlight people where you'll get the greatest yield of undetected lung cancers. Whether it's a COPD because of its mechanical changes that cause the lung cancer, I doubt. I think what happens is that the sort of person whose lungs can be damaged by COPD will also be the sort of person whose lung inflammation will go on to develop lung cancer. I think there's more work to do in this, but it's clearly a strong association.
Right. Thank you so much. Would Dr. Dhar or Dr. Samadder like to add anything to this?
I would like to add one thing is that, as you know, any kind of irritant is a potential risk for lung cancer. So as we all heard today that, COPD has a correlation with smoking or any pollutants in air. So this population is a high risk for lung cancer. And we have to be very, very vigilant in screening these patients. And I agree with Dr. Calverley that this is a risk group which is highly susceptible to get lung cancer as compared to the other lung diseases.
So
can I ask a quick question to Professor Calverley and Dr. Samadder? So just a minute. So Prof, talk us through the benefits of simple things like walking, for instance. Helping people walking. Sort of any form of aerobic exercises like walking, for instance, in places like India, where a structured program for rehab might not be possible, even home rehab might not be possible.
Yeah. I think walking in general, most of the evidence from across the world shows that the more exercise you take, the lower will be your mortality. And although there's always a sort of circular argument in this, I think there's no prospective studies to say that people who were active when they were younger were less likely to develop problems like heart disease when they were older. I think doing that's important. I also think it's important if people who have COPD and stop taking exercise because they get breathless can learn to, as it were, live with it and not be frightened of that. And that can be done in any sort of daily exercise. As was stressed by Dr. Samadder, pulmonary rehabilitation is not just an exercise program, it's also a lot of other information. And I think condensing that and making that available to people in a way they can use that in their home exercise, in their daily activities. To some extent, it's a matter of making sure you do enough of it. Now, my experience of India is that people take a lot more exercise than we do in the West. And all you have to do is look at the body mass index to see why. So I don't generally think that's an issue. The main thing is when we develop COPD is to encourage people that it's safe to continue the usual levels of exercise.
Sure. Dr. Samadder, a little bit about personal breathing, etc. for the audience.
Breathing is interesting. And there's a whole complex physiology and controversy around it. For the people who don't know what I'm talking about, it's where when people are breathing out, they purse their lips together and do that sort of maneuver. Now, mechanically, it almost certainly doesn't do anything directly to lung mechanics. But what it does do is it slows your breathing down a bit. You consciously increase the amount of time during expiration, which allows your lungs to deflate more and you feel more comfortable. And actually, that's a virtuous spiral, because if you feel more comfortable, then you'll relax more, and relaxation will also deflate the lungs.
Can I ask you a question?
Yes.
Nirmalada, we can hear you. Go on.
Oh, we've lost him again.
Yeah, we've lost him again.
Difficult internet.
Let me give my 10 cents of advice of walking. I know in India there is a lack of rehab labs, but what we can suggest is that graded exercise, we believe in pulmonary rehab, that's the protocol. So if they are walking, same walking, if they can do a brisk walking, that will help in improving their lung function, rather than same level of exercise every day and day repeated. So if they can do a graded exercise walking level, that will be helpful.
I think it's also a fact that one thing which my travels to India tell me is that everybody's got a mobile phone these days. And most mobile phones have a timer app on it. And if you get somebody to do the same amount of walking, but at a slightly faster speed over a period of time, if they're willing to, you can simulate that sort of graded exercise. And I think it's using novel ways like that that can, in quotes, low resource settings, it's not really low resource, but you can get people to do things that will help them.
Nirmalada, all yours, if you can hear us.
Yes. Now, before we conclude, I have a last question. Is there any food that can aggravate or improve COPD? This question is open to you all. Is there any food that may aggravate or improve COPD?
Diet's been a fairly controversial area. I absolutely agree with what was said about a healthy diet and a balanced diet that promotes appropriate amounts of vitamin and mineral intakes. That's general good sense. There's no diet I'm aware of that specifically makes COPD worse. So you don't have to stop eating your favorite hot curry. But equally, on the other side, there's no diet which has been shown to affect COPD very much. Not quite the same is true for asthma, of course. There's a whole different topic in asthma. But in COPD, I'm not aware of any compelling evidence about a specific diet. I'd be happy to hear anything my colleagues have.
Dr. Bhattacharya, National Institute of Lung over here, they have published some articles that a diet high in fruit, vegetables, oily fish, and whole grain cereals improve FEV1. So, as I agree with Dr. Calverley that there is no diet which has been promoted, but that has been shown to improve the FEV1. And also, I told vitamin E, A are also very essential in improving FEV1. So,
my only concern about those studies, just to interrupt, is that they're basically observational
Dr.
data.
Samadder,
They're large populations, and the interventional randomized controls, for instance, with vitamin E, have been rather disappointing. So I'm cautious about making complete recommendations, although that diet you described is a very healthy one, which is well worth pursuing for lots of reasons.
So Nirmaloda, along with that, I think
Dr.
there's also
Samadder, can you say?
Sorry, go on.
No, I have a request for Dr. Samadder. Can you please mail me that article so that we can post it on our website? If it benefits some, why not? Yes, Raja, please.
So Nirmala, the only problem is what Professor Calverley said. I think this is actually anecdotal. There's also data about carbohydrates in excess amounts causing damage of the breathing muscles in the long term, which has never been proven beyond doubt. So I think the important thing here is to make sure that people who have a very low BMI, so a very low weight, or people who have a high weight, so who are obese with a BMI of above 30, actually do worse from COPD. So the aim would be to keep a balanced weight, and that would be through a balanced diet, which both Professor Calverley and Dr. Samadder spoke about. I agree completely that there is actually no diet which can make your COPD better. And equally, there is no proven diet which is going to make your COPD worse. The correlation with the weight is far more important as compared to particular dietetic items. Having a healthy diet is probably the way forward here.
Absolutely agree with that.
Nirmaloda, are you there?
Okay, now let us conclude. I thank all of you. It was a nice evening for us. We learned a lot, and if you permit, we'll put your video on our website so that people... Hello.
Yeah, we are.
We can hear you, Nirmaloda.
Our next webinar is on the subject breast awareness on breast cancer. It is on 6th of February. So I'm not sure whether you were able to hear me or not.
Yeah, we can hear you.
Yes, fine.
Thank you. Thank you, everybody.
So I think there is some problem with the network. So thank you very much. Thank you, Dr. Peter Calverley. Thank you, Raja and Dr. Gautam Samadder. I think our viewers have been benefited to a great extent. Thank you very much. All the best to everyone.